Today we're going to look at two things Medicare Advantage really needs to consider or at least sharpen to continue its exponential growth instead of plateauing, right? So this is important to the future of Medicare Advantage, and I'm not trying to be a critic as much as I am extrapolating where some flaws are that we could improve. And this is a conversation that could really help the system overall, agents and MA carriers. MA is going to keep growing. And if it's going to keep growing, providers have to want to participate. Right now, there are two main issues, at least that I'm hearing from the physician side as well as practice with agents. The first would be reimbursement problems, and the second is administrative complexity. This is Ansel with probably a 5-minute Medicare Minute. Let's jump right on into it. So first I want to start with Medicare Advantage reimbursement to providers, that being doctors, clinicians, hospitals, whoever the provider in this instant is. Traditional Medicare already is not paying physicians large enough amounts compared to commercial plans or group plans at that. And it's not like some controversial thing. We talked about this yesterday. MedPAC has a great article on this where they're showing that for over a decade, physician payments for Medicare have grown much slower than inflation has. So that means in real terms, CMS's payment for traditional Medicare to a provider has actually decreased over time. And doctors already accept these lower reimbursement patients when they accept Medicaid or a Medicare patient. But when you move into Medicare Advantage, I've heard from some physicians that, at least I've talked to, there's an interesting thought. Most MA contracts are paying around Medicare's fee schedule, or in some cases, slightly above it. So we're talking anywhere from 100% of traditional Medicare's fee schedule to 105%, 110%. Maybe someone has some unique contract of 120%, but usually it's roughly the equivalent of what traditional Medicare is reimbursing a doctor at. So I want you to put yourself in the shoes of this physician, right? From their perspective, if the reimbursement from an MA is similar, at least roughly equivalent to traditional Medicare, but the administrative work is significantly higher behind the scenes, that math then becomes much harder for them to justify to be a network. With Medicare fee-for-service, physicians know exactly what they are dealing with. You've got one payer, one national rule set that all people in network have to follow, one fee schedule so you know what your dollar amount is, and one billing structure that works the same whether you're in Texas, Georgia, Hawaii, Alaska, Washington, or New York, right? So when a physician goes and they hire a billing specialist who understands Medicare and they're moving from Washington to Philadelphia, Pennsylvania, it's the same exact claims and submission process that they're used to, even in a different state or county. That consistency really matters operationally when we're talking about billing. Now let's compare that to Medicare Advantage. Every MA carrier has their own systems or way of filing claims. Not only that, they all have their own portal that they want you to use. They all have their own unique set of prior authorization rules and restrictions. Even with the same insurer, these processes can vary depending on which plan you have and which region you're in. So if a doctor or a physician goes in and they hire someone who's been billing traditional Medicare for years, that experience will transfer quite literally anywhere in the nation. But if they hire someone who is billing a specific Medicare Advantage plan in another state, especially if it's a regional plan, those systems don't exactly translate nearly as easily to that physician's practice. The billing workflow then is going to look completely different. The authorization processes that they have to go through can be completely different, and the appeals processes can be completely different from one top Medicare Advantage carrier to the other. That means now the practice has to spend time retraining staff, and healthcare practices are already dealing with extremely high turnover in their billing department if they're not just outsourcing it to a third party because it's not worth the headache to them. So when doctors look at MA contracts, they're often doing a simple calculation for their practice. Number one, does the reimbursement that I'm receiving from this carrier justify the operational complexity? If the answer is yes, you know what you're going to find out? Overwhelmingly, physicians, hospitals are willing to participate. If the answer is no, then they begin limiting participation with those plans. So they narrow their panels and they decline certain plans because it's not worth the headache for them. Or they focus on the models or the carriers that reduce their administrative burden. And that's something that MA should think going into the future about how to win over physician practices, hospitals, clinicians, and any providers. Because Medicare Advantage has real strengths, right? Not just surface level strengths. They have real foundational strengths with care coordination and out-of-pocket protections, supplemental extra benefits, and managed care tools that can help them and the physicians control their cost. But if the provider participation becomes difficult and their network adequacy becomes the next challenge then that they'll have to overcome, because access matters. That's one of the main drawbacks to a Medicare Advantage plan is your network. And if you can't go see your doctor or specialist, you're probably not going to choose that plan. Patients need physicians who are willing to serve them in those plans. So if an MA wants to remain competitive or attractive to physicians, there's two main levers that could help. The first is economic, right? The reimbursement that they're receiving needs to be competitive enough to offset the additional administrative work that traditional Medicare doesn't have. The second is on the operational side. If they can simplify their prior authorization workflow, their billing stress, and their administrative processes, that would overwhelmingly go towards reducing friction for those practices. If they can improve in these two areas, provider participation becomes much easier. And when provider participation improves, access for all members improve. MA is not going away. We made this clear the other day. It is a major part of the healthcare Medicare system at this point. So the question's not whether it grows. I don't think that's really where we should put our finger at. The question is, how well will it work for everyone involved? Because even the people who lay claim for prior authorization restrictions at the foot of the billing department, even if that's a fair assessment, if the billing department continues struggling with these requests, struggling with these claims, struggling with these filings, that doctor will leave the network anyways, even if it's not the carrier's fault. Sometimes the most important improvements, they come from listening to the people that are actually delivering the care and not just from us agents parroting something, right?